And now I'd like to introduce our next speaker, who is Dr. Joshua Trigg. Dr. Trigg is a research fellow at Flinders University in Adelaide and an affiliate researcher at the Tobacco Endgame Centre of Research Excellence. His research focuses on health and occupational health risk factors, risk attitudes and motivators of risk behaviours. He has experience working in academia and also previously at the Cancer Council South Australia, where his research examined community perceptions of culturally focused tobacco cessation messaging. He's the chief investigator on an NHMRC MRFF grant that aims to design health communications to prevent e-cigarette use in young people. And I'd like to welcome Dr. Trigg to the microphone to deliver his presentation on perspectives on limiting tobacco access and supporting access to nicotine vaping products among clients of residential drug and alcohol treatment services in Australia.
Hi everyone, hope everybody's awake. Today I'll be talking about a sub-study associated with a larger clinical trial looking at people who are discharged from residential alcohol and other drug treatment and some qualitative work that we did around their perspectives of that experience, but also some qualitative work we did around their perspectives of a few measures that might be used to reduce access to combustible tobacco and increasing access or making it easy to access nicotine vaping products to support cessation and abstinence on discharge. I'd like to acknowledge my other co-authors on this, and we do have a paper written up about this that is submitted for review at the moment. I'd like to acknowledge the land that I work and research on at Flinders University and acknowledge that it's unceded Aboriginal land as we stand on here today, and acknowledge any Indigenous peoples that might be present online or here. So we know that tobacco use is bad. We've heard a lot about that today, obviously, but my work in this case focuses on people who are a priority population who might not be captured in other surveys. It looks at specifically people who have gone through residential detox treatment. They have a much higher tobacco smoking prevalence. They have a much higher likelihood of having substance dependence problems that are associated with tobacco use as well, and a much higher likelihood of having a mental health condition in the past 12 months. So these things combined make it more difficult for them to address things like tobacco cessation and nicotine treatment. Because of this, they have a higher likelihood of relapse after being discharged and a higher likelihood of failing their quit attempts. So most resume smoking after they're discharged from treatment. As we've heard from some other presentations here, relative access remains an issue. So we have tobacco products that are readily available across retail settings. We have healthcare settings that are smoke-free or ostensibly smoke-free, and that includes residential withdrawal facilities. But we have ready access when people are discharged. So that poses a problem for tobacco abstinence once people leave treatment. Nicotine vaping products, however, aren't permitted to be used in most healthcare settings. They are very difficult for people to access for cessation purposes, except on a prescription basis or through illegitimate means, and even more so now. So that also poses a problem for tobacco abstinence on leaving healthcare settings. So that is one approach people can use aside from traditional NRT, combo NRT. So we need to look at how we might modify tobacco access and environments in order to support cessation, and we need public support from impacted priority populations. So we want to know what these priority populations would feel could best support them on discharge. So off the back of a qualitative interview that we did focused on their clinical trial experience, we asked these people about what they thought of retail reduction measure, VLNC cigarettes, so follows on nicely from Carly's presentation, and subsidised access to NVPs and e-liquids as something that might help support them in remaining abstinent. So the specific questions here are, how effective do you think these measures would be for helping you to stay quit from tobacco? And we asked them about gradual retail reduction as opposed to abrupt retail reduction. We didn't use the term VLNCs in the question that we asked them. We asked them about reducing the amount of nicotine to make them less addictive relative to alternative products. And we asked them about whether or not they felt subsidised access to these devices would help them on discharge. And the point at which we asked them was after they'd been through a cessation trial and had a bit of time after that and a follow-up call as well. So they've had some time to reflect on this, And here are some details of who we actually talked to. So it was 31 Australian service clients who currently or previously smoked. About half of them indicated that they were potentially still smoking at the time of the interview. That's not reflective of the trial. All had completed the program. We had 19 interviewees who had used nicotine vaping and 12 who had used NRT, and both had access to Quitline. More males than females, and we had people from Victoria, Queensland, and New South Wales. Nearly everyone we talked to or interviewed here were being treated for alcohol as their primary substance of dependence. Did the qualitative analysis, thematic analysis approach. So in this case, we dual coded and looked at reliability of coding as opposed to thematic analysis proper, I guess. And if you're interested, the parent trial is called the NEAT trial, and the numbers there. So what people thought about retail reduction, these are the primary concerns that they had. So travel time and expense concerns. They mentioned that it would just be more of an inconvenience for them because they would feel compelled to buy these products elsewhere. Admittedly, that is what we've heard from the tobacco industry that would be a concern, but this is people saying this themselves, unprompted in this case. They thought that they would seek alternative tobacco sources. So there's acknowledgement that there's other places they can purchase it and illegal places that they can purchase it, and that they might have to pay even more. And they don't know if that's the best way to do it in this case. And there's always somebody that will bring them to you. So you can actually have them delivered or brought to you. You don't have to actually go seeking this out at a different location. That's easier. The language people used around retail reduction when talking with me was one associated with bans. So they're like, bans don't work, this doesn't work. So whenever somebody talks about any kind of retail reduction, a lot of people jumped to thinking about bans. So they conflate these two things. So that's something that will need to be addressed in communications around these kinds of measures. For a VLNC cigarette standard, we did ask about that. Some of the expected concerns came up. So reduced product appeal, which is the ideal here, I guess. But they felt it would drive them to seek the original product. They'll get what they want to get. In this case, one person mentioned. They'll seek out other full nicotine products. So altering the makeup of the product itself is going to piss people off and drive them to an underground supplier that delivers a traditional cigarette. So that may be, some people will seek that out. I don't know him. A lot of the conversation focused on expectations of compensatory behaviours, so the ones that we talked about just then, but looking at how they would seek to continue the smoking behaviour by using traditional cigarettes, smoking more cigarettes, smoking illicit cigarettes as well. So these are people who had both been part of the NVP condition and a nicotine replacement condition as well. So some of them had had experience of using a vape, which is an alternative, and none of them offered that they would potentially use that as an alternative if this came in. One person mentioned that nicotine dependence is socially embedded, so that's echoed throughout the other conversations that we had, but they explicitly mentioned it here, saying that it's just one aspect of the addiction, and it doesn't really address all the psychosocial stuff if you introduce a reduced nicotine content cigarette. Subsidising NVPs and e-liquids was something that was very appealing to people who had gone through the trial, who had been involved in the nicotine vaping arm of it, but also to people who are involved in the nicotine replacement arm of it as well. So they brought up that it would meet financial concerns for people coming out of alcohol and other substance treatment facilities. These people mentioned that they don't have a lot of money. They are dependent on things like Centrelink. They do have other social factors at play that mean that they may not have supports to find alternative means of dealing with nicotine dependence on discharge. So subsidisation of this option might be something that could help them. They did mention it's supporting health equity. So this was around, I think about 7 or 8 participants mentioned this, that people who end up in these kinds of facilities are by nature of ending up there of a different socioeconomic stratum, but also they have other considerations as well that make health equity a priority for them. Managing perceived and actual access barriers. So people talking about access to it. There is the ability to access NVPs using a prescription system at the moment, but people considered that very difficult, more difficult now. And they still acknowledged that alternative means of sourcing this might not be ideal or certified or clean, more questionable for them, and they didn't particularly want to do that. So they acknowledged that that is a legitimate route that they would like to use, but too hard basket in some cases. So the conclusions from this study is that there's a need to reduce tobacco access or relative access to minimise people's contact with environmental triggers when they come out of these services, and support access for cessation alternatives that might help meet equity issues and reduce tobacco-related burden for this priority population. A retail reduction generally prompted a negative reaction here and thoughts of compensatory purchase and smoking behaviours. Thoughts don't necessarily equate to action, so you would need to see what people actually do when these measures come into place. Participants did note that this is needed to address the high retail tobacco availability though, so they did accept that it was something that was useful. Very low nicotine content cigarettes, similar concerns. They thought about product switching and non-retail sources, black market sources and the like. And for subsidised access to NVPs and e-liquids, they thought of it as an equity issue, and they did acknowledge that there's a role potentially for subsidised access to these products, and that it was positively received by these participants within the trial generally. So they, in this case, in this qualitative study, generally felt that this was the most acceptable of these three options that were presented. And I will say that we selected these three options to ask them about for brevity. It was included as the tail end of another interview, or of a single interview, and looked at the literature at what was most feasible and what was likely to be rolled out in other places as well, so we could prioritise what we asked them. The next steps are obviously to look at what clients of different healthcare provider types might think about these measures and other tobacco control and endgame measures potentially, a wider range of cessation support and tobacco control options, and looking beyond measures provided for in the recent budget. So we might look at things like penalties for having places that are festooned with environmental triggers. I'm interested in how clients across these providers will manage when new measures come into place. So formal strategies that are endorsed and informal strategies are things that people do. I'd be interested in running a survey on that and looking at how we can support equity in access to different types of cessation measures. And we can talk if you're interested. Thank you.
So do we have any questions for Dr. Trigg in the room? No. Well, I've got a question about the context that people were answering their support or lack of support for the different measures. It sounded to me like a lot of them were thinking in terms of that they still wanted to keep purchasing tobacco and still wanted to keep using. So was there any nuance in those who were envisioning that they weren't smoking and wanted to remain not smoking, and how that might support them rather than in the context of someone who wanted to keep smoking?
So the question we asked was about what would help them or best help them when they're discharged. There were a few people in there who said, I'll continue smoking, very few of them. The rest, we just accepted that they may smoke, may not smoke, that sort of thing. It's what they felt would have best supported them on discharge as well.
Yeah.
So I guess that nuance would require a larger sample.
And obviously there was that comment in there by at least one person. I don't know if there were other people also brought up about the prescription model. So obviously some support there for it being more medicalised access with some controls and restrictions on what products were available, so have some quality control and so on. So was there much discussion about sort of the current situation and if that was more readily accessible via, you know, a wider range of general practitioners?
Yep, so not included in this presentation, but there were a number of participants who talked specifically about interactions with GPs and online services and things like that, about trying to source nicotine for their devices, mostly around barriers, impediments, and how they felt it was difficult, but in some cases around how the healthcare professionals felt it was too difficult as well. But I would say that needs to be tested more widely as well.
Yeah, so maybe once the changes come in place, looking again to the same population to see whether they are finding it easier to access products that they trust, and also getting maybe more support from healthcare professionals in that. Got a question from Ron.
Yeah, you talked about the alternative products in terms of subsidy, but a probably more realistic model is a price differential so that they're cheaper than cigarettes. Was it explicitly about subsidised or being cheaper than that you were focusing on, and do you think it would make a difference?
So the question, the discussion was started around explicitly talking about subsidy rather than relative price. Later on in the interview, people tended to talk about relative pricing, and some people mentioned taxation and that sort of thing as well, but that wasn't prompted, that angle.
And the same sort of positivity about relative pricing that you got for subsidy, was it or not?
Negative.
Yeah. Were there any other questions or online? Does anyone have any questions to put to Dr. Trigg about the research? There's one over here.
I don't know if you can answer it or not, but it always amazes me when we're talking to clients in AOD treatment services, when we talk about the issues around alcohol or the primary area they're there. Is there any conversation, you sort of alluded to it, around cessation of tobacco while they're also dealing with the alcohol and other drug issues? Because the pairing of that stuff together, there's really good evidence around that. Is that the resistance from the staff, knowing that, or is it just not a conversation? Because I've often wondered that.
So that sort of information will be bound up in the trial reporting more so. There are other aspects of the qualitative interviewing that address the person's experience around that. There was some mention of it in the stuff that I did later on about once back in the community, how they balanced their re-experiencing of their primary substance dependence in relation to using tobacco, but that wasn't a focus of those interviews, but it was still in there. Yep.
Yeah. Okay, and we don't have any questions online, so we might thank Dr. Trigg for the excellent presentation.